Good afternoon.
Good afternoon.
Oh, we are going. Hold on. It says the stream was deleted. Huh. Are we live? Oh, we are live. Okay, great. We are live. Let me go over to Instagram. Amanda Marino here with Levels Without Limits. And we have a special guest today, Dr. Mangrola. Could you introduce yourself to everyone who's on YouTube, LinkedIn, Facebook, Instagram?
Yes. Hi. Hi, everybody. My name is Raju Mangrola. I'm a board certified psychiatrist. I'm in practice in Jupiter, Florida. I've been in practice for a fairly long time.
How long?
30 years.
30 years.
It's probably the same spot or the same look, maybe moved a little bit. But I worked outpatient, inpatient, rehabs, held positions of medical directorships for well-known places. I was at Hanley for 6 years, medical director. Prior, I also worked with Crossroads Center in Antigua for Eric Clapton. I'm the consultant there. Work with hospitals, doing consultation with Jupiter Medical Center, see patients in the office. So I do a lot of forensic work too, doing IMEs. So,
You're a busy man.
Huh?
You're a busy man.
Yes. Well, I mean, it's you pick what you want to do. So
you're passionate about helping people, and that's one thing. That's why I wanted to get you on the camera in front of more people, because I think you have a fantastic background, and I love the way you view things. It's unique, in the topic that we've discussed. But I at lunch, I was bringing up to you doctors that haven't been around for 20 years, and you knew that. That worked with me when I was a teenager, and everyone knows you who's of credibility in our community, and appreciate you.
Thank you. That's very nice of you to say. So
absolutely. Well, I have to give Brad Sylvain a shout out. Hi, Brad. Thank you for connecting us originally, and also other peers. So we at lunch started talking about the Baker Act. This is a topic. There are a lot of videos by different attorneys and things like that made on this. And tell me how many patients you've had Baker acted in the past 10 years.
Well, depending on the setting, if in my office, maybe one or two, maybe even less, maybe one. Hospital setting, rehab setting, probably a handful. So we try to work with them as much as you can, because there is always a factor that if they can connect with you, it usually works out. But then there are situations where it's very black and white that they need to be Baker acted, and you have to do it. So
yes. But I just loved your take on it. It just seems, in my experience of what I've seen, it's like sometimes people are just so quick to go right there and not do steps before that. So what would you want to share with someone about how the Baker Act is beneficial and how it could be not the best option in your experience?
Well, I think the Baker Act was passed in 1972 by a representative named Maxine Baker out of Miami. She was part of a very strong mental health advocate, and they were primarily provision made for people with mental illness, and they were housed in state hospitals. They needed they had no rights and all that. So this allowed them to have the rights and give them 3-day assessments. And so really what happened was this was more geared towards that kind of population who are at risk, psychosis, danger to themselves, others, violence, suicidality, and all, name that. But as the time has gone, we have seen a shift in some ways with new onset of people getting depressed, new onset of people overdosing, having suicide risk, and attempting to hurt themselves. They may not be very severely mentally ill, but they have stresses in their life. The lifestyle of people have changed. So has their response to the stress.
Yes.
And they may have a depressive episode, or they may be in the beginning of a bipolar or some kind of drug-induced psychosis or depression, whatever. So that shifted the focus of how the Baker Act is utilized. So I think the way I see it is Baker Act is definitely has its place. It allows the person to go to a safe, the safety is important. They go to a hospital, they're evaluated. But the goal of the Baker Act was to allow them to go and get treatment. And so it just allows that 72 hours is just a window of time so they can convert, they sign in, and they can get the treatment. But in this day and age, the insurance companies, they breathe through your neck. They want them out. So barely they may be there for 2-3 days and they're discharged. So if you really think about it, are they really getting, I mean, I'm not saying they don't get the help, but there's in and out process. And there's so much, the whole process of Baker Act, when the patient is handcuffed and taken to the hospital, to the psychiatric facility, it's very stigmatic. It's very shameful for the person. They get very upset. It's traumatic for them. And that's what people remember. And that's what people think about. And we don't have any way around it because that's the law. Exactly. That's the law. So if I have a patient who has those issues, which are very real, but on this, you have to weigh that risk benefit analysis, so to speak. It's that, let's say you have an elderly person, having them handcuffed going to a psychiatric hospital is not the best scenario.
No, that can hurt. And then, if there are a lot of, police departments that have been educated on mental health, but there are some that aren't, they don't understand.
They're very stern, and it's not that they're doing their job, but there's a lot of gray area in between. So that's where your ability to, if you can work with them, there is a better system. You have to develop a support system. I'm not saying you walk away from a Baker Act, but you can come up with a better contingency plan to treat the person without their need to go to the hospital. Now, when I said I maybe have Baker Act 1 or 2 people in the last 10 years or what, it's because I would take the time, or my office would take the time to work with the patient. They have a good rapport with me, Therapeutic Alliance, and rally around them, develop the family support. And if I have to see them every day, or if I have to call them more than once a day, keep tabs till they get stable. I remember in one of your cases where I had seen a patient in the hospital, that you guys provided that immediate support and one-on-one care for them, avoiding the hospital. It was an elderly person, and it worked very well with liaison with another psychiatrist, So I think the point I make,
sometimes teamwork can work.
Yes, teamwork works. So that's the whole idea. And it's not about, I think, Baker Act. And I think the other thing is important is the non-mental health professionals. I'm talking about non-psychiatrists, non-physician psychiatrists. I think mental health is a difficult subject for them, even today, even though there is a lot of awareness. So they are only looking from a point of caution. So they rather take the step of Baker Acting somebody and then make sure they're secure, they're safe, and then take it from there. So now as a psychiatrist, I would be able to understand the dynamics better than they would. They're just doing their part. They're just doing their work because they don't know they don't know which way it'll go if the person is not Baker Acted. Especially in emergency rooms. We see this all the time. The emergency room is probably the most vulnerable spot for a patient to elope, hurt themselves, or do some kind of strange activity that could be pretty dangerous. So
when they're waiting in the emergency room before they go back, is that what you're saying? Or when they're waiting?
Yes. Or they may not need they may not need hospital admission. They may not need a hospital admission. They are making a threat. They need to go to a facility. So doctor's first response is evaluate. The emergency doctor if they need to be, they're based on their own criteria, they'll correct them. They'll call in the psychiatrist, like they'll call me. And then I'll see the patient while they're in the hospital or while they're in the emergency room and evaluate. Okay. And many times it may be bringing the family together, and they may not have any other history. They may not have any other history for having some sort of mental. I mean, if it's a clear-cut mental illness diagnosis, they have bipolar disorder or schizophrenia, it's a whole different story. You're not going to waste, you're not going to debate that. But somebody who's new, I think you can work with them.
Like situational or new presenting mental health?
New presenting, yes. So the doctors, then they lean toward, they want your expertise to evaluate and to work it out. A lot of times they may not need a Baker Act, even though the doctor did it. I'm not saying that's every case, but these happen.
Well, that's good that the emergency room doctors are having, professionals like you come in and assess before they go ahead and do that. That's hopeful to know, because I heard in another state, I was speaking to a family in a different state where the gentleman was put in the emergency room for psychiatric, and he was waiting for a bed in the psychiatric unit, which I guess is their version of a 72-hour hold in the state. And then he got discharged before he even made it to the psychiatric. So he never was ever evaluated and was just sent home. And
that happens even in local hospitals. That happens here in this community, because if, let's say, there could be the units are full, the psychiatric units are full, and there is no other way to. Emergency rooms they're required to clear the patient. That is, they cannot hold somebody there. But but even though they say that, they hold the patient still if there is bed needed. So they will call in a psychiatrist, or they'll call in another mental health professional to evaluate, and they may not be admitted, and they think they are deemed to leave, they will let them go. I'm not saying that it's hit
right or wrong.
It is the circumstance. So
so I remember I think I shared with you, my mother was the admissions psych nurse at Fair Oaks for many years. So they always had that one unit that was on property, and then they added another unit in the emergency room for psychiatric. So a psychiatric emergency room unit. And then if they get admitted, then they go over to the Fair Oaks part of Delray Medical Center. Yeah. It's strange to me how our society sees mental health and health as two separate things. It's one thing.
Yes, I still say this, even though there is awareness of mental health, even though there's awareness of all these psychiatric conditions, the media, whatever, everybody, even though the awareness has gone up all over this country, the stigma is still there.
Absolutely.
I see the stigma still there. I see if the person looks a little odd, or they have made an attempt, or they're angry, the professional doesn't want to deal with that situation because there's nothing medical. Let's send them back to the psych unit. Now, there may not be any reason, Right.
Maybe
that's where somebody like me has to get involved and evaluate the situation, and but that it's a difficult position for the people. It is. And
the stigma and the shame. It's interesting. Some of the families that we work with, some have stigma around the mental illness part, and even though addiction is a mental illness, so some are okay with saying their child has like depression and anxiety, but they're not willing to say that they have a substance use disorder, or vice versa. They don't. So everyone has a perceived thing in their mind of like what is okay and what is not. It's all okay. Everyone's going through something.
Yeah.
So many people struggle. I mean, COVID was a curse and a blessing at the same time for mental health, because it gave us much more of a voice. I think more people felt safe to reach out because they had no choice.
Yes,
what's your experience since COVID time? What have you seen shift?
I think the whole, whether you call it the invention of the video conferencing, video evaluation, it really sprung. It took off, and a lot of telehealth medicine, mental health, telepsych medicine all came up so fast, and it allowed people to be, even in remote areas, underprivileged areas, to get help, especially in veterans. It became a very effective tool for using telehealth. Veterans are in further away places, and I think it was definitely a benefit in that regard. And just like we are talking today, I can see a patient on video, and it makes the job easier, and their compliance supposedly can go up because they don't have to come. They don't have the means of transportation to come to the doctor's office or to their office. So definitely there was a plus. Now, there's still a big debate about whether telehealth, that proponents say that the telehealth is as good as seeing them face to face, which I have a problem with that. I think you're going to miss something there. There is room to miss something, which may be minor, but I see that. I see that in my practice. So
yeah, I mean, the ideal world would be being able to do a combination, right? Having that personal relationship and sometimes in person, and then also for like the reality, like you said, older adults. We do work with a lot of older adults, or individuals like that travel a bunch. I travel so much that for me, if you would have told me before COVID that I would see a therapist virtually, I would have told you no way, never.
Yeah.
I've been with her the longest I've been with anyone because I can, because I can, you know what I mean? On a busy day, I don't have to drive to, the appointment 30 minutes away and drive home. You know what I mean? It really makes it feasible for me to see her every single week.
Right.
And I believe it now, but I mean, we've also met in person and things, you know what I mean? Like I do think in an ideal world, it would be combination would be great.
Yeah. So I think the jury is still out about the long-term impact with telehealth and how successful it is. That's just my opinion. How successful it is. The proponents say it's very good as face-to-face. As I said, I have a little problem with that, but that's not that's my bias.
30 years of experience talking right there, and it's valid and it's heard, and all opinions are welcome here on Levels Without Limits.
Right. So the other thing about Baker Act is that you try to work with them. It really matters. I think what I've seen with these patients is there's a sense of desperation. And then you throw in the Baker Act. I'm not saying everybody, they get even more angry sometimes. Like a lot of younger patients, you tell them you need to Baker Acted. You have to be careful how you approach that. If they need to be Baker Act, they have to be Baker Act. But sometimes you got to work with that situation. If you have a better alliance with them, you can work. And again, it's a big judgment call. Somebody can come back and say, Dr. Mangrola, you're taking a risk by letting them go. Well, it's a risk. I wouldn't say, but with experience, you have some judgment. You have the calculated risk, or it's a reasonable risk, whatever. The point I'm making is more often than not, it has worked out. More often than not, it has worked out. They will follow through with you. They will follow. You got to have a backup plan. If they're going to let them go from lifting the Baker Act or let them go, you've got to have a good backup plan. So that's important. So
I should have probably started with this, but it just came up. So if someone is watching this and they don't know anything about what is a Baker Act, you said it when it started in 1972, and it was meant for a certain population, like individuals that couldn't really function. So how would you define it or share with someone who has no idea? That's just kind of, this is popping by their screen.
Baker Act is a provision in the law for mental health treatment. Basically, the technical definition, or if you want to define it, it allows a person, if they are danger to themselves, danger to others, or they cannot take care of themselves, and because of that, they can be at risk to themselves. And as a provider or a police officer or whoever the provider is, a medical provider or a social worker, they have the ability to have them commit for up to 72 hours, send them to a psychiatric hospital. Mm-hmm. And this can happen in any setting. This can happen in emergency room. They can happen in nursing home. This can happen in person's home, but the police can go and they can assess the situation. All it does is it removes the person from a critical, dangerous spot to a safe spot, like a psychiatric hospital, where they have the ability, and it allows them 3 days to assess. In that 3 days, the person can consent for treatment and establish a treatment plan. And if they need more time to be treated, that's what it does. So the the other idea of the Baker Act was to preserve the patient rights. It allows their freedom is still there. Although they're confined in a hospital, they have privacy, they have access to family contact. All of that is still open. They have access to an attorney, all of that. So it's a big package, so to speak. Baker Act is not just taking them from place A to place B, but there is more to it, as far as patient rights are concerned. And that was the whole idea of putting the Baker Act in place.
So a question, in an ideal, in an ideal world, someone who's presenting maybe suicidal or like a harm, you said, harm to themselves, harm to others, or presenting, not able to take care of themselves, one would, assess in a perfect world, a psychiatrist would assess and say, okay, this person, it would be good for them to be stabilized for 3 days and then reassess. And so is that kind of what it's meant to be? I mean,
that's correct. That's correct.
Just for everyone, that's why, because there are times in people's lives where they don't know that they need the help they need, and certain things like this can come in. I do think I'm pretty wide open on social media at this point. At 18 and 19 and 14, I think I was Baker acted. And one was behavioral, because I jumped out of the second floor window and to sneak out. So the cops took me because I was not compliant to the psych hospital, Sandy Pines, where we talked about. And then at 18, and I was terrified. I woke up and I was in a room at South County with two women one was talking to the wall and one was terrified to turn the lights off. So I was just, I was drug induced, had behavioral problems, things like that. And I can still remember very clearly, and I'm 44 now. So this is a long time ago, but it was a very traumatic experience back then.
Yeah, it can be.
Yeah. I mean, it definitely is somewhere I never, ever want to be again. So, right. Definitely take care of the mental health. But
it's important. And we don't, let me just say, as a physician, we are so trained to be on the side of caution, which is the right thing to do. Safety is the right thing to do. But we also need to spend time to think the other flip side, like what impact do they have? What impact a Baker Act, just like what you described, would have on a person. It's important. It doesn't mean you're downplaying, you're enabling them now. You're not enabling them. It's important to separate that, but to understand the dynamics and to work with as much as you can with them. That's the key. So.
Yeah. And I think that it's really important. And, the hospitals, the psychiatric units are generally, understaffed, many patients per, client. And it would be wonderful if each person could have this solid, strong discharge plan of what to do next, and connect with professionals. And sometimes that happens, but sometimes someone just gets put outside. Like, I know a family I'm speaking to now that has a loved one in the Baker Act unit, and they want to have a plan for them, but they don't. Last time they came out, they called them when they were out front. So and that's not anyone's fault, right? This is just the conditions of what we have. Could it be better? Yes, it could be better. But in an ideal world, that's just a state. If it is utilized, it's just to stabilize. And then that's just, and then what do you do after is really what I think, seeing a professional such as yourself.
I think I hate to say this, but we have psychiatric hospitals, but the aftercare is still a missing element. It's not a strong element. A lot of these patients, they fall through the cracks. We see this all the time. Yeah. And it's a shame, but again, that's the way things are, yeah. And it's hard to get doctor's appointments. It's hard, there's a waiting list or 2 months, 3 months. A person discharged right away, they need an appointment within a week or less,
Right.
So if I'm seeing a patient, if I feel like they are safe to go home, my office, we will make sure they will call my office within the week or within the first 2 days that they're going to follow up. And my office knows that I saw XYZ and they're going to see me in my office. And I make sure, because it's not only responsibility, I have to make sure I'm covering myself too.
Absolutely. You can't fix the system, but you can make sure how you show up for yourself, your patients.
So that is a very, very important part, because the family's first question is, doctor, can I call you? It's the first question comes, and you cannot say no to that.
Yes. Well,
you may or may not like the patient, but you have to say, yes, we'll see you.
Yeah, I mean, and then the family support is a huge piece too. So if you are a family member as well and watching of a loved one that has any of the things that we've kind of discussed, you yourself should get support too. This is mental illness and substance use disorder. All of these things really affect everybody. And, I know that the reason I had started my company, I worked in residential mental health programs and substance use programs doing outreach. And I noticed a thing. There was when people would either discharge a stabilization unit or a program, they'd be given a piece of paper and here's your discharge plan. And that's great. And it sounds great, but it's really hard to actually walk through and implement, right? It's hard to take those action steps by yourself when you're scared of other human beings, you're scared of yourself, you're not, you're still getting stabilized. So I felt like a little hand holding, for a little bit and then titrating that down, because I remember the model that they used on me after in between the Baker Acts was like the beat you down to build you up model. And I was already a traumatized young girl. So beating me down didn't help me. I needed support and kindness and compassion and love and the right meds and, things like that. But I needed, so we try to, meet people where they are and not beat them down because they're already beat down. They're hurting.
Yeah. Yeah, I think that whole concept of beat them down, strip them down it's pretty controversial. It's not advisable at all. And there were programs that people still did that, but it's in this day and age, no, it's absolutely a no. So
yeah, as an adult, when I went and toured an adolescent program that was compassionate and kind, and had the parents do work and was very I gave the autonomy to the kids. I got very emotional and I was like, God, I wish this was around when I was a teenager. This is so beautiful that things are, so there has been progress. There is progress. We still have so far to go. I'm going to speak in Dubai in December on opening up a mental health concierge business in the pre-pandemic. So while my mom's texting me, telling me, oh my goodness, everyone's losing their jobs, everyone's struggling, myself and my former business partner, we were so busy because mental illness and substance use was insane. And my older, the people that taught me, my mentors, they couldn't travel and things like that. I was young and healthy. And so we had to come up with all kinds of creative ways to meet people and help people in that time. It was insane.
Yes. But I think, your interest in helping them is so important.
Yeah.
And people are afraid. People are afraid, genuinely afraid of psychiatric disorder. They're genuinely afraid of psychiatric patients. And that fear factor comes in the way of somebody trying to help them. That could be a family member, that could be a provider, or it could be somebody else. So I think it's important that barrier has to as a physician or as a provider, somebody, a mental professional, it's my job to help them in that process. I try to do that.
That's why I don't do anything without a psychiatric, psychologist, clinician involved. Because I am not that. I have a different skill set that can complement those things, but I never do anything without a clinical lens on anything I do. It's dangerous. And I will no longer do an intervention. We learn as we go. So some interventions, the family members thought that the loved one was on substances, and it wasn't that when we got there. They were in psychosis. So that is, you don't want to intervene on someone when they're in psychosis. You want to help guide. I will from afar help guide the family to reach out to their psychiatrist, figure that part out, and then let's have a conversation on what what we.
You're the boss. You direct the people.
Well, they direct me. I actually need to be asked. I need to be deeply managed. Ask Sarah. So we do the clinical rounds every week with our psychologist, Dr. Hutman. It happened from 11 to 12 today, but we partner with the great professionals like you guys. But it's I just loved hearing you say, when we were at lunch, we're just discussing the Baker Act and the importance of it, and then when we can avoid it and when it's being misused, or maybe misunderstood.
It's more out of caution and fear. I think they're probably the two main factors I see.
Yeah.
Yeah. Well, they would take care of somebody dying with chest pain, they're comfortable. But if there's a patient who looks a little strange or whatever, there is a distance between the patient and the provider. It just, I don't know what, it's human emotions. Dealing with emotions is one of the hardest things for him. Even though we are the best at dealing with it, we are not the best.
No, it's tough. Listen, the world we live in hits you with all kinds of things. And, so many people struggle in silence, and then they have a break, and then they can't keep it in anymore. And then there's people that have just continual, have been like over and over the same kind of scenarios, hard to find the right medications. Like, so what do you do if someone, is like medication resistant in some kind of way, like you've tried a number of things with them and they don't work. Do you believe that any of that testing works? Any of the testing for meds?
You mean the medication, whether they work or not?
Yeah, like, there was for a while, there was a blood test or a swab.
No, it's still there. There's still a lot of it's still pretty popular. I have utilized it, but I think there was a big push. They compared the psychiatric medication testing to cancer treatments, which is not the same. They're two different things.
Okay.
They're two different things. But people's perception is okay, I'll do the test and I'll find the right medicine. That's not the case. All the testing does is allows you to evaluate whether you can tolerate the medicine or not tolerate.
Okay.
So the medicine you tolerate, the chances are you can work with it better in terms of side effects, in terms of So if a medicine is metabolized normally like everybody else, your chances are better to respond or taking it for a certain period of time or certain dosage. But the companies, and I don't blame them, but people's perception is, well, if I do this test, I'll find the right medicine.
Right.
There's no such thing. That's what
I wanted.
Psychiatry is still an art.
Yes.
And finding that combination is still an art. As much as the science is there, art in psychiatry is still very important. Yes.
So the art is your education, your experience.
Art is my education and my ability to tease out what could click with this person with the medication. I mean, we've been treating these patients for a long time, even before these testings came out, and they responded. They came around. They all did well. So it's not that that art skill was the skill of the art, whatever you want to call it, art skill was still there,
Yes, it's still very much needed. I remember, I've dealt with families and individuals. So it's interesting how one medication will make someone, feel like how they react to it. I know, like if I'm to take a Benadryl before I go to bed, it makes me awake. So that it just everything chemically, but you get to know your patients, their history. Yeah. Some people are SSRI, or at least they think they are, like resistant, like it doesn't affect them. And then one thing I find interesting too is individuals that have just been on a massive drug or alcohol run and say, I don't want to take any psychiatric medications. And I'm like, okay.
They're using the worst drugs for their illness, but not one psychiatric drugs. Yeah.
Yes. Listen, I'm proudly on an SSRI for 20 years and I don't care.
Yeah.
Why change it if it's not broken?
Yes. Well, I mean, all the mental health conditions, substance abuse, they are chronic conditions. They are no different than high blood pressure, diabetes, arthritis, heart disease. So you need medication for long term. That's the understanding, So
yeah, and it's not, and it's not for my place that I'm at now. It's not a stigmatized thing for me, right?
Yeah.
I went through childhood trauma, ages 4 to 7. I told my first therapist at 7, was on medication first at 7. Yeah, okay. I'm 44. This is not something that's just going to get put over here in a cute little box and not be an issue anymore. It's going to be something. Yeah. Of course, I know it's much different now today, 20 years into the healing process, but it definitely is just something that I always have to keep an eye on. And thank God I know, I've learned about myself. I've learned lots of skills and tools, but it's really important for myself to have a psychiatrist and a therapist for myself. I just keep those in my world.
Well, I mean, it's, I've used this analogy. There's not scientific, but the 30% rule, like 30% medications do their job, 30%, 40% therapy. The other 20-30% is what you do, what changes you make, to make it a whole pie,
Yes.
So
it's going to be one or the other. You're not going to take a magic
it's
pill
not.
and your life is going to be amazing either, right?
Same thing with substance abuse. Substance abuse is the same model. You got to utilize all the important elements of treatment. You can't just do one or the other. Just 12 steps is not enough. You got to have other tools. So
yes. What do you recommend in that regard? I mean, I know every individual, like individual is different, and I love that we are in that version of this, we're shifting into that version of this world when it comes to substance use, that there is not just one way to recover and heal. There's a lot of ways.
Yes, there are a lot of ways. I mean, there are a lot of models now out, there's a lot of branched out models from coming out of 12 steps, similar to 12 step, similar principles. I tell patients that some patients get very upset with the 12 step idea, religious idea, but it is behavioral science. 12 step is behavioral science. So it is a form of cognitive behavior therapy. If you really think about it, it's you apply it, not somebody telling you what to do, but it's your way of providing cognitive behavior therapy. So that could be a very good form. If you have some other tools that you need to take medication, you take emotional condition, you take care of that. If you have cravings and if there are medications available depending on your drug of choice, you can utilize that. Having a good social support system is important. So all those little things, not hanging out with drug, I mean, whatever. I mean, I'm just saying,
changing your people, places, things.
Right. Yeah. So, but that is also part of, this is one thing I'm going to point out is we as psychiatrists have shifted away from just managing medicine. And I think that's a drawback for us. If the patient needs some form of therapy, and if I'm a psychiatrist, they can see a therapist. But if I can offer them 2 more cents in therapy, it'll carry a long way. I will take the time to give that. I'll take the time to talk about that. They can still see.
I honor you for that. I told you about one psychiatrist I saw where it was literally like pop in, how just as you're in there writing this, 0 connection time, just rewriting the same script and in and out the door, boom. And that's a shame. And it's a beautiful thing that you give your
patients, they would like to be respected and they will understand you much better if you spend the time. And we make sure we don't overbook. We see them on their time and we respect their time. I'm not late, and I'm not trying here to talk about my practice, but I think that the idea of utilizing therapy, medication, giving them the time, giving them the respect, I think it really carries a lot of weight. It takes a long way.
Yeah.
So patients feel valued. Psychiatric patients feel valued. It's very important. So
one thing I would add to your repertoire of tools would be individuals finding some kind of passion and purpose. I know that we're finding that with a lot of our older adult females that feel like they've lost their sense of passion and purpose. So they're on the psychiatric meds, they're going to therapy, they're trying support groups, they're doing all the things, but they feel like, kids are grown. They're thinking there's nothing left for them. So finding passion and purpose, and you can find that at any age. I've had 80-year-old clients find their new passion and purpose, whatever that may be. But it's really important to find something that makes you feel alive.
Yes. It's a very important, you brought up a very important point. We see that quite a bit of that in this community. Yeah. And they could be functional in a lot of ways, but they have a hard time with finding passion. And if you can help them there, it's a big plus for them. So definitely.
Yeah, it definitely breaks my heart when you've lived this full, beautiful, abundant life and you have successful children and grandchildren and all these things. And then, you're looking at, okay, what do I have around the corner for me? Nothing but dying. That is not, there's so much you can do anything you want at any age. And I believe that, with the right support around you, the right professionals such as Dr. Mangrola, at any age, you can change your life. At any age, you can find passion and purpose. If you feel like you're too mentally gone, there's hope for you.
There is hope. There's hope.
There's hope.
Definitely, there's hope. Yeah, the people do come around. I'm not going to, even for substance abuse, people come around. They're more, yes. You cannot just go by the statistics now. That's.
Is there one case, just not obviously not super detailed, that you would share of somebody that maybe seemed like you weren't sure how they would do or if they were going to be okay, where they now live a good life?
Yeah, I can share that. I had a person, a high functioning individual, referred to me. It's probably 6-7 years ago, and they were in their late 50s, and he had a business in somewhere else in New York. He was in finance, and he used to travel there and stay there for 3-4 days, come back. His wife didn't know what he was doing. His business was not doing well. He was with a partner. They owed debt. They owed money. They owed money to IRS. Anyway, he got so upset. He got into drugs, got into indiscretionary behavior, all kinds of, ended up in the wrong part of the town in New York. I mean, all kinds of stuff. He exposed himself in a lot of bad ways.
Yes.
And 5 professionals had seen him. And then they came to me. And I saw him the first time, very angry and this, that, verbose. My first impression was, he has bipolar. Well, I was wrong. So he came back again. He was coming on a weekly basis. His wife says, I want to sit into this meeting. I said, yes, you are very important in this. Usually we don't, but in this case we did.
Yeah.
And she started sharing some of her concerns. And all I did was just let him talk. And there was a pattern of change that he broke down after 2 or 3 sessions. He literally broke down in my office, started crying. He says, this is the first time I was able to tell somebody that how my mom beat me when I was young. He was the only child, and she used to beat the hell out of him. The father had died when he was young, and that stayed in his mind. So his way of, if something goes wrong, he would rebel. He will just thrash everything. That's how he coped with it. It was kind of you can say it's a male borderline or whatever. You can say that. I don't think the diagnosis mattered in this case.
No.
But instead of being
and held inside all those years.
Yes. Instead of his being bipolar, he was very depressed. He was very traumatized. He had probably had PTSD at a late age. All he did, started coming to see me, his wife was coming slowly and surely. He was drinking a lot. He stopped drinking. He started taking naltrexone. He was put on a little bit of antidepressant. He was able to join another big company, EY. EY is a big, Ernst & Young. And he had a lot of skills. He was all pushed away because of his craziness.
Yeah.
He joined them. They hired him as a vice president. He was able to pay back all his debts, travel with his wife. His relationship with his wife got better. She never left him. That was very critical. She could have left him.
Right.
Guess where they are today?
Living a beautiful life.
Yes. He moved to Portugal, retired there, bought a place, and he's living there. And every year, twice a year, he'll send me a postcard.
Oh, that's beautiful. I love that so much.
And his line is, Doc, if you write my story, I want to be on the cover page.
That's great.
I want all the rights. I want half the money if you write a book on it. But this is a real. It changes life. All we did was let him open up.
Yeah.
With all this, So
I remember I'd say about 9 months ago, I visited that forensic hospital in Miami. I visited a psychiatrist friend down there. And, I sat with him and his intern, and they were sharing with me what most of the people were, they were living there for 10, 20, 30 years underneath, whether it's in this residential or they're stepping down to houses which are right around the area. And a lot of them had childhood trauma. And it made me so grateful in that moment that my mother put me in therapy at such a young age and got me the help that I needed in my adolescent years and those things, because that could be me. If I didn't do the work and I didn't get the right help and right medication and right support and right healing, I could have been one of those people, And so this gentleman who held it in all that time, that's my big message I want to get to the world. That's my biggest goal. Like, I don't want to speak to more people at behavioral health conferences where everybody knows what's what and what, all the different things. I want to reach out to people that have never, ever heard that there's help or hope for them. That's who I want to reach.
Yes. And I do believe that strongly, that the cases are not dismal. They are not, mental illness is not a dismal situation. No, it's not. If you can understand the situation, you can do a lot of work with them and improve them 100%.
So if someone say watch this today, and we'll start with, if they are struggling, what would you recommend they do? If say they're just struggling with mental health, where would you recommend they start?
I think if they need to seek out to see a professional, but whoever that may be, could be a psychiatrist, therapist, get some kind of assessment. And you got to give them a choice. Let's say the person comes, let's say I call them, yes, I'll see you. I talk with them. I got to give them a choice. I'm not going to come back and say, you got to go this, and this. No, you got to give them this ability to make that decision.
Yes.
And you got to empower them in that sense.
Yes.
And that's what gets them into understanding they believe in you, because it's hard to buy psychiatry. Okay. So I'm not trying to sell them anything, but if somebody calls, they should be able to understand, yes, I think this person understands me. I can find a way. I can have some hope, but that's what your role is. You
want them to have autonomy, and you want to have them have some skin in the game, because if they don't have any, then that's not going to work. So you're giving people options. We do the same thing. We got to give up. No, all the time, they're not a right fit for us. Like I will refer directions. And if I refer to programs, I give them multiple options. It's just the right, because I agree. I'm with you on the autonomy
and I have to admit that you can be very direct with patients. I've been told I'm very direct with them. They appreciate that. They like that. They don't get offended, because they see that you're coming from a different angle.
Right.
And they may get mad. They come back and they say, no, doc, I understand what you're trying to say. The point I'm making is we have to reach out as much. They're not going to come to you. You got to reach out to them,
Yeah.
So
I love that. And family members too, same thing. There's a lot of education on, NAMI, about different mental illnesses. There's organizations that, there's all kinds of different support groups out there for families, but, definitely reach out to a professional such as Raju Mangrola, a licensed professional who understands mental health and mental illness. It's just really important. And it's not, if you or someone you love have anything going on, you're not alone, and there's no shame. I know a lot of people carry a lot of shame with things with substance use disorder, mental health, eating disorders, very shameful. There's no shame. It's okay.
Yeah, it's okay.
Through something. And if you're reaching out for help for yourself or for a loved one, then you're in a very small percentage of people actually doing that today.
Yes, there. Yes, true.
So how would you like to close it up? Is there any last words you want to share with my live audience? And this will continue to stream, so I'll also be able to share with your friends.
I think my 2 cents in this is that we have got the training, we have learned the skill. We should have some interest in taking care of these people. We should have compassion in taking care of this. It's one of the hardest population to deal with, but if you can make the cut, I think it's the most rewarding place to be, working with this group of population. That includes substance abuse, that includes mental health. And that's my message. I have done all kinds of things work-wise, and I don't regret it. I don't regret it at all. Not a single piece, So again, it's not about, but all I'm saying is you got to take interest in the patient. That's very important.
And what do you do to throw you a little curveball? What do you do to take care of yourself? Because this line of work beats people down. And So I know that you told me you just recently started taking vacations. I'm going to push you to take more vacations, but what do you do to keep yourself okay, to be able to handle it all? You just born like that, or
is what?
Are you born like that? You're just born with that grit?
No, I was born with that grit. I would say a lot of people call me a workaholic. It's fine. My office manager called me a workaholic, and I am taking more time off. I do a lot of reading, non-medication, medical related stuff.
Yes.
Fiction books, non-fiction, travel for sure. Gardening, it's a big passion of mine. So, those kind of things. So,
yeah, those are great.
And BSing with friends. So,
yeah, that's great. That's great. Listen, we all have and I know that there's a lot of doctors in the family from what you said. Your son's.
Yeah, my dad, my son, myself. Yeah.
Yeah, I love that. Keeping it going. But your son is doing pediatrics, correct?
He's pediatric ER. He just joined the Nemo Children's Hospital in Orlando. He's going to be on the faculty there. So
congratulations to.
He doesn't like psychiatry.
You told me, he said no psychiatry, Dad.
So.
No, I appreciate your openness to share. Do you have a website, Dr. Mangrola, I can type in here for people?
It's Raju Mangrola MD.com. MDPA.com, I think. Yeah.
So. MD period?
No, MDPA.com. I think there's
MDPA? Sorry.
Yeah, I don't even look at my website, so give me 1 minute.
Okay. I can also do it after if you want. Are you on social medias?
No.
No, good for you.
I have this fear that patients will find out and they will come in. I don't know.
Believe me, listen, I've been hitting social. It's like I told you, I opened the business right before the pandemic, so I had to lean into the virtual world. And boy, people can be not nice on social media. Thank God for the block feature.
Yes. So I try to avoid it.
I've also met the greatest people too, all around the world.
I don't know. It's there. I'll send it to you. So.
Okay. You send it to me after this, and I will make sure it gets put up here on the link, especially on LinkedIn. I think that, that's a great place. I've had some people reach out to me in a DM message that have never, ever reached out to anyone or told them anything. And then I'm able to, because, picking up the phone, it can be scary. So if sending a DM and then to point you in the right direction, hey, whatever works, and you're not alone.
Yeah, whatever works. Yes, that's correct.
So thank you so much for your time today.
My pleasure. My pleasure.
And soon. And I appreciate you in our community. We're so blessed to have you in the South Florida community, and Jupiter Medical is definitely blessed to have you. And your patients are really fortunate, because that's just not the standard. I mean, that's most of the psychiatrists we work with. Very few.
Yeah, I think the people you mentioned, the psychiatrists you mentioned, they're very well liked. So
yes, is this someone you know? Because I know Rajav.
No, I don't know them. No.
See, there's a couple people in the waiting room that maybe try to come into the stage.
Yeah.
But a few people said thank you both. Very informative. We appreciate it. Yeah, if you have any questions for Dr. Mangrola, since he's on social media, I will add his website, and then you can also reach out to me and I can point you in the right direction. I'm Amanda Marino, owner of Next Level Recovery Associates, and Amanda Marino Speaks. And this is Levels Without Limits. And thank you so much. We had amazing Dr. Mangrola on today. Have a great day, everyone.
You too. Thank you very much, Amanda. Thank you very much. Bye.
Bye.